Welcome, everyone. I'm excited to welcome you to this episode of the Sunflower Podcast, a podcast exploring all aspects of children's palliative care around the world. Sunflower Podcast is going to bring curiosity, humor, and reflection to the world of palliative care as we explore the joys and challenges of working in this incredible field, including topics related to education, advocacy, self-care, service provision, and leadership. I'm one of your hosts, Dr. Megan Doherty, and today I'm at St. Jude Children's Research Hospital in Memphis, Tennessee, as part of their annual Global Scholars Program, which brings together 30 incredible healthcare providers from around the world to learn and deepen their knowledge of children's palliative care. I'm excited to be joined today by Dr. Mike McNeil.
So nice to see you on the podcast today. Would you just introduce yourself to our listeners? Because I think some of them know you, but we'd love to hear your experiences and where you're working. What brings you to our show today?
Absolutely. So it's a pleasure to be here. My name is Mike McNeil. I am a combined pediatric oncologist and palliative care physician, and I am the director of the St. Jude Global Palliative Care Program here at St. Jude Children's Research Hospital in Memphis, Tennessee.
Thank you, and welcome to the podcast. Like I said, so excited to have you on the show. And we really wanted to hear from you. You know, you've got this combined experience of being an oncologist and a palliative care trained physician as well. And this is really an advantage we wanted to hear from you about. So what do you find are some of the challenges of introducing palliative care and bringing in that palliative care approach for some of the patients that you care for?
Yeah, I think one of the more common opportunities that we have for improvement or challenges is this perception that palliative care is the same thing as end-of-life care. And we know that WHO definition of palliative care is so much more than that it's really the prevention and relief of suffering of patients and families. And so that's probably one of the biggest opportunities that we have. And that perception is seen both in the medical community as well as sometimes within the general community as a whole.
And how do you address that with your colleagues? Because obviously you know that as a palliative care provider, that it's not just end-of-life care, but I'm sure that message has to get out there to others who don't practice.
Yeah, we try a couple of different things to address that. One is through opportunities for education, through different forums that we have, educational sessions in the institution, curricula that we've developed for our pediatric oncology fellows, that there's an integrated palliative care component to that training. The nurses in the hospital being able to get some of these things, as well as just kind of those one-on-one opportunities as we are able to interact with our colleagues with a particular patient who is having a high level of suffering and how to be able to incorporate that care to help address those patients' needs.
And, you know, are there any groups of patients that you think need an automatic consult or automatically need palliative care, or how have you done that at St. Jude in terms of what groups of patients you see?
Yeah, so we've actually had really good success in our bone marrow transplant unit. And so all patients who get a bone marrow transplant here actually receive an automatic consult. And it helps demystify that for both the patients and the healthcare team by recognizing that this is a standard of care. As a patient goes through something as challenging as a transplant, that we are not just focusing on the cure itself, but also recognizing the importance of quality of life as they're going through this treatment. And so we do actually have a physician and nurse practitioner who help spearhead some of those efforts and see those patients.
That sounds like a really successful integration and collaboration. We were chatting earlier about phase 1 trials and integrating patients and integrating care with those patients. How's that going? How are you doing that?
Yeah, so phase 1 trials, right? You know, for us in the medical community, we use phase 1 trials to really understand what is an appropriate dose to provide a patient. And that is something that we use, and patients who are often on phase 1 clinical trials are those patients who have had multiply relapsed or recurrent disease or hoping for another opportunity. And yet the perception of what the goals are may be different for families who think that this may be there for another potential cure, where for us, really the goal is to understand what is a safe dose. And so these patients already come in with a lot of needs, right? There's multiply recurrent or relapse disease. There's a lot of symptoms that they may already have. So that's another opportunity. And we have had the opportunity for some clinical trials, in phase 1 in particular, where we do get involved for all of those patients to be able to help navigate the complexities, especially because a lot of these patients are referred from outside of the Memphis area. They're coming from around the country and around the world. And so some of the social challenges that they face and how we can help navigate that as well.
And you were talking about the fact that, like, you know, even if the patient being cured, they are sometimes needing palliative care. You were saying all patients with cancer need some level of palliative care, perhaps. How do we do that, especially globally? How do we make sure all those children with cancer get some palliative care? There's not enough palliative care specialists or teams to do that work. How do we get that knowledge out there? How do
Yeah,
we address that?
great question. And one of the things that, as you alluded to, there's only a certain number of folks who've received formal palliative care training, especially in pediatrics, right? And so there's a couple of different levels to approach that. One is the recognition that there's something known in the literature that we see called primary palliative care. And that is any healthcare professional can be a palliative care clinician who provides good quality palliative care. Anytime someone provides an opioid for pain, anytime they provide high quality communication, they are doing primary palliative care. And so we can educate the entire institution or the entire workforce on some of these basic principles so that every patient everywhere has the opportunity to get that support. Then there's the specialty palliative care. And that's really where there is a finite level of resources. And so that additional training to have an understanding of refractory pain, difficult conversations, the psychosocial elements of care complex. And so for them, it really is kind of focusing on what your resources may have. You may not be able to see every patient. And so focusing on those patients in which there are high levels of suffering. It does not necessarily have to be those that have a terribly poor prognosis, but it may be a patient with certain types of brain tumors where they have a lot of symptoms and they have a lot of suffering. And that those patients really benefit from someone who is really focused on how to address, manage, and alleviate some of the suffering that they go through as they're receiving their treatment.
So it doesn't necessarily just have to be, okay, all the kids who really we don't think we're going to be able to cure are those ones who have really high risk disease. It's also looking more holistically, the ones who really need our support.
Exactly. And that's why, one of my interests from an oncologic perspective are those children with solid tumors, because they have a lot of suffering, from the location of the tumor itself and the pain associated if it's a bone tumor or if it's in the belly and it's causing compression of the intestines, making them really nauseous. So even if there are patients that their overall prognosis is pretty good, they still have a lot of symptoms and a lot of suffering. And so those are the type of patients that there could be a great opportunity for palliative care to get involved to address those needs. And so it does not always have to be just those patients who have poor prognosis.
I think that's really important, that holistic approach. Yeah, it's good to see how you're addressing that. I want to shift gears a little bit. I've been at St. Jude with you for the past few days, just walking around, absorbing the atmosphere of the place. And, this is an institution really focused on finding cures, saving children. That's their motto, their byline. How do you work within that, in the fact that you're doing palliative care, that not every child is finding a cure or being saved? How do you address that?
So this is what brought me into this field to begin with, right? When I was in medical school, I was certain I was going to do orthopedic surgery. And it wasn't until I did a pediatric oncology rotation and had a patient who, after relapsing, the family decided comfort measures. And I was really distressed by this until one of the attending physicians at the time, who had done training in both oncology and palliative care, highlighted and said, we may not be able to cure every child, but there's always opportunity for healing. And that really struck me. And I completely shifted gears and in a completely different field now. And I don't regret it. And I think that the mission here is absolutely essential. And we do hope to one day be able to cure all children. And there's going to be a lot of suffering in that process, right? Even as we are able to cure, the distress, both psychological, both physical, both mental, emotional, existential, is there. And so we have to incorporate understanding of supporting them in their quality of life as we're working to seek these cures is essential. And I love being able to be at a place like St. Jude where we are able to incorporate those things and learn how to address those needs, how to support these patients as they're receiving this care, and as we're trying to continue to move and advance the field forward to result in cure, and that we can also have that emphasis on healing as well.
That's really interesting. And just love for you to tell us about your research. You've been doing some research in, I heard, over 50 countries, a study called ADAPT. Tell us a bit more about that and how it's changing the field.
Yeah, so as the director of the Global Palliative Care Program, we're really interested in really defining the state of palliative care globally. thinking about different interventions to improve capacity in these states and really working with our collaborators around the world to do this. And so one thing that we've really learned in the study that you're alluding to is this study is a survey that we've sent out to physicians to understand what their perceptions are of palliative care for children with cancer, what they know as compared to WHO guidance, what they see as these perceived barriers to earlier integration, and their comfort level in being able to provide care for patients who are suffering. And it's been really interesting. As you've alluded to, we've now been able to do it in multiple regions around the world and multiple continents. What we found is that the overall knowledge and foundation of what is palliative care is actually fairly high, and that their beliefs and understanding of palliative care is consistent with a lot of WHO guidance. However, the comfort level is low in being able to provide this care. So, for example, in the study that we did in Latin America, we actually found that only about half of the physicians feel comfortable addressing the physical needs of their patients. Only about a third felt comfortable addressing the emotional needs of their patients. And only about a quarter of the physicians felt comfortable addressing the grief and bereavement needs of parents and other family members. And so there's this gap between what we know and what we feel comfortable doing.
How are we going to fill that gap? It's obviously not a knowledge gap.
Yeah,
people know this stuff.
That's the thing that is exciting and challenging, right? It is just giving a lecture on what is palliative care. It appears it is not going to be enough. And so how do we provide colleagues around the world an opportunity for actual skill-based practice, really being able to be on the ground and practice this medicine in a tangible manner is one of the ways that we're trying to address this.
And I heard you launched a new fellowship in Guatemala as part of this initiative.
Yeah, so really thinking about, a variety of different opportunities, whether that is a couple of weeks of an observership somewhere versus more kind of a couple of months to even a formal fellowship. And so we did in collaboration with the hospital in Guatemala, UNAP, as well as with the University of Utah. We have launched this formal year-long fellowship to be able to get that tangible training and this experience, and then being able to return home to practice in their own settings and build that capacity there. And our hope is one day, and our vision is to be able to have multiple opportunities like this at a variety of centers of excellence around the world to really be able to bridge that gap between what we know and what we feel comfortable doing.
And, there's a few other fellowships around the world. I know St. Jude is also supporting palliative care diploma programs in South Africa.
Correct. Yeah. So the University of Cape Town has a pediatric palliative care diploma, and we're excited to be able to work with them and support a couple of participants in that. We've loved working with you and Two World Cancer and being able to support all of the educational opportunities, both virtual and in person, throughout South Asia. And really, that's the thing, is the recognition that if we can create these centers of excellence in the different regions around the world, that can provide this foundation to build off of, and folks can be able to get at these experiences a little closer to home that they can then bring back to their own institutions and practice.
I love that goal. I think it's the goal we all share. I want to go back to one interesting thing that we were talking about that we didn't quite round out, which was just talking about the idea that palliative care is not the same as just end-of-life care. We talked about how we address that barrier amongst healthcare providers, but I know that's also a myth that just the general public and patients and their families might have. And how do we kind of navigate that and address that with them?
Yeah, so there was a wonderful study that was done a few years ago by Dr. Levine here at St. Jude that they actually were able to show that when you provide appropriate education and knowledge to the patients and families with regard to what is palliative care, the vast majority actually felt quite comfortable and said, yes, I want that in my care, right? And so often when we think of, the patients and families, they're just not ready for palliative care. That may be us as the medical community that has that concern and not necessarily the patients and families themselves. And so again, educating our colleagues, but then also educating our patients and families about what that means, as well as kind of thinking about ways to address that in the community as a whole by demonstrating and highlighting some of the work that we do.
And I know your palliative care team here at St. Jude is called Koala.
Yeah.
Tell us about how that name came about. Why did you decide that and not just the palliative care team?
So again, those two words together, palliative care, sometimes have a preconceived notion and this perception that brings anxiety to people. And so to be able to overcome that, this idea that really what we're doing is trying to provide quality of life for all. Koala was a way to really open that door so that people who may have a preconceived notion of what is palliative care can say, oh, well, yeah, absolutely. I need to be thinking about our quality of life as well. That's been really important. And I think it really has opened doors both for our colleagues in the medical community as well as families.
That's really interesting. And would you recommend that? Like, what do you think? If a new palliative care team is starting out somewhere around the world, should they go for a name like Koala, like a name that doesn't have the word palliative in it? Or what do you think?
I think it depends on the circumstances and on the needs. I think that there are two kind of views in this. One is that, no, we should be named palliative care because that's what we are and that's the right term. And there's the other view of, hey, we just need to get in the door. So if we need to change the name, let's change the name to something that is more approachable. And I'm kind of in the middle. I think that, our global program is called the Global Palliative Care Program. And I think that it is important that we help address that misperception. And inpatient team is called a quality of life team, right? And so I think that it can be a little bit of both. And so I think the recommendation that I would give to anybody who's starting this is to understand what is the current state in your practice setting. And if there are really strong preconceived notions of what is palliative care, maybe thinking of another name that can open doors. And if there isn't, then maybe you can, from the very get-go, be able to help demonstrate what is palliative care and overcome some of those things.
And I love how you said about really, if you educate the families, this is actually something that they would want for their child's care. So a little bit the onus is on us to do the work.
Absolutely.
Well, I want to wrap up there for today. Thank you, Mike, for being on the podcast, for joining Sunflower. And we're so thrilled to be here with you today. And thank you again to St. Jude for hosting us for today's podcast.
Pleasure being here. Thank you so much.